osteology from the lateral skull view, and it is a small in size, containing neurovascular structure that we will show in a while. This diagram will show you the boundaries of the pterygopalatine fossa from the lateral view. You can see it's bounded anteriorly by the posterior wall of the maxillary sinus, purple in color, posteriorly and superiorly by the by the pterygoid process, and medially by the palatine bone, as we will see in more details. So, in order to understand the anatomy of the pterygopalatine fossa, osteology is very important. So we will go with a few slides about the osteology of the pterygopalatine fossa. This is frontal view of the pterygopalatine fossa. As we can see, we are on the left side. This is the superior orbital fissure. This is the sphenoid sinus, both pterygoids, lateral and medial, and the greater wing of sphenoid. What we can see, the pterygopalatine fossa is in this place, so occupying this space, and we will talk about the foramens and fissures in a while. And when we bring the palatine bone and cover part of the sphenopalatine fossa, it will show that the most of the content of sphenopalatine is hidden behind this palatine bone, and most of the content is in this quadrant. Okay, we will follow the way of assembling the bones of the area. So this is the the sphenoid bone, as we can see, bilateral sphenoid, bilateral pterygoid, and this is the area we will target. This is the sphenopalatine fossa, and this is separately the palatine bone. We can see the horizontal portion of the palatine bone. This is the perpendicular plate of the palatine bone, and superiorly it will branch into two parts. This is the orbital process, and this is the sphenoid process. In between, we will see the sphenopalatine notch, where the content of the sphenopalatine will go medially. When we put this inside, assembling again, we will see this is the floor, this is the hard pellet, and this is the medial wall of the posterior part of the maxillary sinus. When you go up, you will find the two process, and in between, the content of the sphenopalatine will go medial. Let's come from the medial aspect. So we are looking at the area from medial aspect. This is, as we said, the palatine bone. This is the hard pellet, the posterior 1/3 of the palatine bone, the horizontal portion, and this is the perpendicular plate of palatine bone, and it is like what we said, branching the orbital process of palatine bone anteriorly. It's very hard bone. You need to remove it before reaching the sphenopalatine area, and this is the sphenoid process laterally, and this sphenopalatine, the sphenoid process, it goes laterally and join the lateral process of the humerine bone to make the what is so-called palatovaginal canal, and we will see in a while. In between, we will have the sphenopalatine notch. As we said, the arteries and nerves comes out of this, and when we put this in this space, then you will see the area is covered. This is the area of sphenopalatine artery from medial view. This is the maxillary sinus. This is frontal process of maxilla. The orbit is expected to be here, and this is the sphenoid. This is the communication of the sphenopalatine fossa down to the oral cavity, and the communication to the orbit superiorly, as we will see in a while. This is another view. It's from lateral view, and as we can see, the whole unit all together. Before that, we can see the palatine bone in green, and this is the maxillary bone in green, and the yellow color is the palatine bone, and this is the notch we were talking about. This is the orbital process, and this is the sphenoid process of the palatine bone. When we bring the sphenoid bone over, it will make us the posterior wall of the sphenopalatine area and the superior also portion of the sphenopalatine area. Finally, the up view. For us, it's less important. It's good for the neurosurgeon, but less important for us. But it will help us in understanding. This is the area of sphenopalatine, the palatine bone, the maxillary bone, and posteriorly the pterygoid bone. So this is roughly regarding the osteology and gross anatomy of the sphenopalatine area. Now we will come to the imaging. I'd like to show you some few images. I'm using this software. It's very good software. It will help you in understanding the three dimensions of the any anatomical structure in the area, and we will target the sphenopalatine area. And now I will convert it into three orientation of the CT scan. So once I press over the area that I want to see, it will show in the coronal and axial plane. So we will come to the axial plane first. This is the sphenopalatine fossa, and this is the infratemporal fossa communicating by the maxillary sphenomaxillary fissure, palatal maxillary fissure. And when we go little up, we can see the maxillary nerve here going through the foramen rotundum. And when we go little bit down, we will see some few landmarks. Still the posterior wall of maxillary sinus, the infratemporal fossa. And when we go down a little bit, we will see this line that comes from posterior, from anterior to posterior, and from from medial to lateral. And this is median nerve and median canal. It goes to the carotid artery, to the foramen lacerum. It is one of the important landmark when you do this approach. When you go a little more down, you can start to see the pterygoid process, both medial and lateral, and you can see this small canal here, which represents the descending palatine artery. On the coronal plane, what we will see is the same almost. This is the sphenopalatine area. If you see something, one structure coming down, this one is the descending palatine artery going to the oral cavity. And if you go a little bit backward, what we can see on the contralateral side, please look at the contralateral side. This is median. Okay, this is the inferior orbital fissure, and this is superior orbital fissure. This is the median, and this canal, small canal, is the palatovaginal canal. There is an important arterial nerve going through this canal and going to the esophagus. When we follow the nerve, the median canal, it will guide us backward to the carotid artery and foramen lacerum here, which is very important landmark for the vitreous portion of the internal carotid artery. Look at the other structure, which is the V2, maxillary division of trigeminal nerve. If you follow, this is the V2. If you follow, it will guide you to the cavernous sinus because it lies in the lower border of the cavernous sinus. Here in the sagittal view, you can see the area. You can see the communication to the orbits superiorly and inferiorly to the oral cavity through the greater palatine canal, and posteriorly, this is the median nerve going backward. This is more explanation about the imaging. Maybe this is more clear regarding some of the landmarks. So we can see here the base of the pterygoid process, and we can see superior, to the process, medially and inferior is the median canal, and superior and lateral is the median, the V2 nerve. And we can see, if we go downward, the median relationship of the median and V2, it's anteriorly, they are close to each other. Once they go back, they are diverging. So the direction of the median is from medial to lateral, and the from below to above, while the V2, it will come from superior to inferior and from lateral to medial. You have to know these landmarks, especially when the pterygoid process is rheumatized. Then you will have both of them. There is a good identification for both of these structures. This is axial view. This is the foramen rotundum, and this is the median. And when we go down, we can see the palatine canal transversing the artery. So, what is the clinical importance of this pterygopalatine fossa? It's very, very important area, especially whenever we have a tumor or infection. It will spread to the skull base, different area of the head and neck through those foramens and fissures. So we have the foramen rotundum, the pterygoid canal or the median canal, palatovaginal canal, palatine canal, sphenopalatine foramen, pterygoid fissure, and anterior orbital fissure. We will see some of these openings and fissures. This is the osteology of the sphenoid bone. As you can see at the top of the pterygoid process, you can see both canals, the median inferior, and V2 lateral and superior. The median nerve, as we know, it transmits the maxillary nerve and communicate the pterygopalatine fossa with what? With the middle cranial fossa. And this is the occipital view. You can see the carotid from the occipital view, the anterior cranial process, and the median is the V2 coming through the foramen rotundum this way and going to the middle cranial fossa to meet the V1 and V3 and form the Gazerian ganglion. And pterygoid canal is the same, but it comes through the fibrocartilaginous structure at the level of the petrous portion of the carotid, which is the foramen lacerum, and it carries the median nerve and median artery as well. Some of the, or most of the cases, the median canal carries only the nerve, and the artery, in some cases, it's a separate canal. We need to understand these issues because whenever we have vascular region like juvenile angiofibroma, if you need to embolize not only the external system, but also the internal carotid system through the median canal to control. Also, whenever you treat the juvenile angiofibroma, you need to cauterize and control this artery. Nothing can explain the importance of the pterygopalatine fossa better than this image. This is MRI of a patient with adenoid cystic carcinoma of the maxillary sinus involving the pterygopalatine fossa. And let us see how these tumor can spread in the head and neck. You can see the difference between pterygopalatine fossa here and on the contralateral side. So the fat plane is preserved and the vessels is preserved, while on the other side it is invaded by the tumor. And you can see the invasion extended through the pterygomaxillary fissure to involve the masticator space, and also through the V2 it goes anteriorly to the premaxillar area, involved in the premaxillary area, and also posteriorly and inferiorly to involve both pterygoid muscle here, and through the the palatovaginal canal it extends to the nasopharynx in this view. On the other view, you can see the median here is involved, and V2 as well. We can see the involvement, clear involvement of the pterygopalatine fossa and the masticator space. Here you can see the extension to the orbit through what? Through the anterior orbital fissure. You can see involvement of the orbit and also the dural enhancement of the middle cranial fossa. So the area is very important area to understand because the extension of the tumor and infection can happen to the orbit and to different intracranial parties. What are the content of the pterygopalatine fossa? As we know, maxillary nerve, the artery, also maxillary artery, the median, pterygopalatine ganglion, and veins and lymphatic tissue. So now we will go to the endoscopic anatomy. So we got the gross anatomy, then the imaging anatomy, and now we will come to the endoscopic anatomy. As you can see, this is the posterior wall of frontal sinus. The maxillary sinus after removing the bone, and this is only the periosteum covering the content of the pterygopalatine fossa and the infratumoral fossa, and you can see most of the content are fat. The first structure that you face on the pterygopalatine fossa is the vascular structure, then the nerve comes after. And as you can see, this is the right side, this is the septum, this is the maxillary sinus, and this is, we removed the bony wall of the Sphenopalatine fossa, and we can see the branching of the terminal branch of the maxillary artery coming out and down through the greater palatine artery. This is a short view, video. I'd like to thank my mentor, Professor Paolo Castelnuovo. We did a lot of efforts he did actually for me regarding this understanding this area. So as we can see, this is the posterior wall of maxillary sinus. This is the branching of the Sphenopalatine artery. This bone is the what we said earlier. What bone is this? Palatine, which part of palatine bone? The orbital process. It's hard bone. We are using here the chisel. We don't use it usually intra-op. We usually use drill, but for the cleaning of the specimen, we are using the chisel. So once you remove this part of bone, then you start to expose the Sphenopalatine fossa. Here we go. The contents start to appear, the vascular and neural structure. First thing appears the arteries, the nerve and the ganglia becomes posterior to it. This is so many branches of the Sphenopalatine artery. It will be discussed by, I think, Professor Kaziano in a while. If we remove the posterior portion, we can see the median comes through from medial to lateral. And when we remove the posterior portion, just a few millimeters of the posterior wall, the medial wall, you can see the artery, and this is the artery. If you want to control the epistaxis, you need to clip it. In the fossa rather than in this area because it might branch before. This is the median, as we can see, and when we dissect, we can see the nerve, the ganglion. This is the ganglion, and again the median. When we remove the sphenoid process of the palatine bone and superiorly part of the sphenoid bone, we will go and see so many structures like B2. We remove the bone now. This is the B2, and this is part of the pterygoid. We can see, so this is the median nerve going to the carotid, to the petrous portion of the carotid. This is V3 through the foramen ovale, and this is B2 superiorly. When we bring it back, this is the Sphenopalatine artery. This is the median nerve going to the carotid again. And here is the V2 going to the middle fossa. This is another dissection, shows the relation of the median. This is the median after we cut, and this is V2. If you follow, this is V2 at the base of the cavernous sinus. If you incise here, you will see this nerve, which is abducent, okay? Abducent. This is the median, again, and this is the foramen rotundum and B2 in this area. Up is the orbital apex and the optic nerve superiorly. Sure. 3 minutes. So, surgical approach to the pterygoid area. Either we go transpterygoid, transmaxillary, or transpterygoid, transethmoid, transpterygoid, sphenoid approach. It depends on the area that you want to expose, whether you need to do medial maxillectomy or just posterior maxillary anthrostomy and reach to the area. And this is the branches of the Sphenopalatine artery, and this is illustrate for you how the configuration comes out from the Sphenopalatine. Median goes straight, the palatovaginal goes to the nasopharynx 45 degrees, and the septal branch of the Sphenopalatine goes around the guana and comes anteriorly. So understanding these structures will help you during the dissection. And this is, as we said, it's just, Sphenopalatine fossa approach. You need to just do maxillary anthrostomy and go to the area immediately. If you want to reach that part lateral to the infratumoral fossa, then you need to do Tinker approach when you remove part of the anterior wall of the maxillary sinus endoscopically. What are the indications? So either we go transpterigoid approach to control the epistaxis or video neurorectomy, or just simple pathology in the area like schwannoma in this case, or in case of nasoseptal flap. What is the indication for transpterigoid, ethmoid, sphenoid approach for more extended disease like stemper canal, CSF leak, fetus apex lesion, pituitary adenoma, craniopharyngioma, invasive papilloma, and juvenile angiofibroma. And this is just illustrated case of CSF leak and meningocele of the lateral sphenoid wall. We do maxillary, wide maxillary antrostomy and complete ethmoidectomy just to reach to the area, identify the sphenoid in this place. Then you do wide maxillary antrostomy. This is the posterior wall, and this is the area of the Sphenopalatine fossa. We go a little more and drill the pterygoid process in order to reach far lateral, and this is the posterior wall contillary sinus. We are drilling the orbital process of palatine bone and removing now the posterior portion of the Sphenopalatine fossa to reach the far lateral part of the pterygoid recess. You can approach it transpterigoid and you can approach it transmaxillary and sparing the tissue. Then you can continue and clean the area. Here, this is the defect, and you can see now we need more drilling of the pterygoid because we need to reach comfortably to the area. This is V2 above and lateral medial to the defect. Then we just did the reconstruction as usually. At the end, I'd like to stress more about the anatomy of the Sphenopalatine fossa. It has very important clinical implication. So studying anatomy and dissection is the best way to learn about this area. Thank you very much.
Thank you, Dr. Abdulaziz. Now we'll start the lecture with Dr. Kaziani, please.
Okay, well, that was a very nice presentation, covering a lot. You know, there's two subsequent. My presentation is a little similar, the paranasal sinus neurovascular bundle. I'd like to, kind of was watching, sometimes you don't know until you hear the previous presenter and maybe gloss over some of the things that have already been presented, so I'll fly through those and maybe touch on some clinical pearls that we have had, and giving maybe some short clinical correlations to this. And maybe you can apply this in the lab when you go back to dissect. So I think you already went through all the important vasculature, particularly of the nose. And you know that although most of the nasal vasculature comes from the external carotid artery through the Sphenopalatine Foramen, there is a portion that does come through the internal carotid artery, through the ophthalmic artery, and then of course giving off the branches to the anterior and posterior ethmoids. Some of you, as we were walking through the lab, were asking where these are, and again, this is an exercise that you need to, they're fairly easy to find. You just have to have the skill set to be able to find it and understand the anatomy. So the areas we want to focus on is the branches that come from the external carotid artery right here, but also branches that come from the internal carotid artery, and you should be able to find these in the lab fairly easily. So when we talk about the anterior and posterior ethmoids, here's a sagittal cut. You can see the maxillary sinus where the M is here with the crest of the antrostomy. I've circled the area that corresponds more or less where the anterior ethmoid air cells are under AE, which is across the horizontal portion of that antrostomy. and then the posterior ethmoids that are PE that are back more posteriorly where the transitional part of the transrostomy is. And of course the arteries that go with these areas correspond with these areas. They're in the general roof of these areas. So when you talk about the last suprabular cell up here, the anterior ethmoid labyrinth, you're talking about the anterior ethmoid artery that's been marked in blue, and the same thing with the posterior ethmoid. And as Dr. Kamal mentioned yesterday, the posterior ethmoids generally lie in a bony canal most of the time. Probably the easiest way to find this one is to actually take the lamina prophysia off and then elevate the periorbital laterally and see as it goes into its canal. You can do the same thing for the anterior ethmoids, but these can be more variable. These can be in the membranous canal and easily injured during the course of surgery. You just have to be knowledgeable where they are, and if you do cut it, try to cut it medially, closer to the skull base, because that way it doesn't give it a chance to retract into the orbit and cause an orbital hematoma. Certainly easy to take care of. If it does bleed, you could just either bipolar or monopolar it. If you use a monopolar suction cautery, be careful not applying the tip of it to the bone around the artery, because as it chars, as you pull it off, you get a CSF leak. So when you're going to do that, kind of keep it off the artery and just let it coagulate. So if you look at the endoscopic view here you have the left side of the nose, and you see the remnant of the middle turbinate, the vertical lamella of the middle and superior turbinate, and the blue line circles, it delineates where the cribriform lies on the other side of that wall, okay? And if you notice, you see the anterior ethmoid artery, where the A is, and the posterior back here. Actually, there's a little middle ethmoid artery coming off the posterior ethmoid artery. You'll see some of that variation, not of any clinical significance, but note that where the arteries repenetrate intracranially medially, generally the anterior slopes anteriorly as it goes and medially, okay? And it repenetrates around the anterior cribriform, It's the opposite with the posterior. It kind of slants posteriorly and re-enters intracranially with the posterior cribriform. So in between the two is the length of the cribriform plate, the olfactory bulb, all right? If you want to find this, take off some of this upper lamina prophysia, which is what you would do anyway if you were going to do a cauterization, for example, in combination with sphenopalatine. And then just elevate it as you see here in the lower figure, and try to see where it's entering the canal and identify it. Same thing with the posterior here. You can actually elevate the periorbita laterally and you can see it. So try that in the laboratory when you're in there. So you already heard about the pterygomaxillary space. In general, and I came in a little late, the most common Sphenopalatine foramen is type 1 that you see here, just a long oval opening. Sometimes you'll have it separated by a little fibrous bridge right here with the superior neurovascular bundle in the upper bigger one, and the inferior turbinate one and the smaller one and the inferior one. And sometimes it can be divided totally by bone. So the reason I put this is that if you have a posterior nosebleed and you're going to do a Sphenopalatine cautery, make sure you go low enough to elevate the mucosa to isolate the potential existence of a separate opening. Because you can for example, ligate or cauterize the lower one, but miss the bigger one that's above it. So make sure you get a wide opening. And what we're talking about is this bone here, the palatine bone, and particularly the front part of it, the orbital process of the palatine bone, because we're going to find that bone, find the pointer, which is otherwise known as the crista ethmoidalis, which points to the foramen, Sphenopalatine foramen. And so when you elevate, this is just out of my book, these are based on real endoscopic pictures, and you can see here, this is the vertical crest of the enterostomy right here. This is the insertion of the inferior turbinate. Actually, the inferior turbinate had been already removed, but normally the upper part of this is the vertical part of the enterostomy. And then you can see there's two separate, there's a bigger opening. You can see the orbital process of the palatine bone right here. And you can see this pointer, and that pointer always points just behind it is the foramen, the Sphenopalatine foramen. Okay, that's the crista ethmoidalis. And then below it, in this particular case, there's a separate artery, and you got to make sure you catch that, because sometimes you can miss it, could be bleeding from that. And then if you remove the bone from that vertical crest of the enterostomy here, immediately One of the reasons you do not do that during an enterostomy and make it flush with the back wall of the maxillary is because of this little artery and nerve, the greater palatine nerve and the descending palatine artery that run right along that crest, okay, right below it. And that's what anesthetizes or innervates the soft palate posteriorly. So you got to be very careful, but you can certainly identify this artery. If you take the fat and the back wall off of the maxillary, and you can see the pterygoid muscles, you can see the branches that go to the infraorbital nerve, or the infraorbital nerve itself. You can see branches going to the pterygoid and the medial aspect of the temporalis muscle. You can see branches coming up and becoming the sphenopalatine and even the descending palatine artery. So I encourage you to do this in the lab and try to find these. You have to tease away the fat to be able to see that. And of course the IMA is the main one that comes from below and goes vertically in the back wall and of course branches into all of those structures. So as you saw before, if you go further back at the same level of the Sphenopalatine Foramen, you'll see the more rounder, not oval, but rounder Vidian nerve. And the Vidian nerve is actually just medial and not be confused with the palato-vaginal canal, which is where the P is there. And of course, it's much bigger, and it's perpendicular to the foramen, the Sphenopalatine Foramen. So they lie like this with each other. And of course, all the parasympathetic fibers enter into the ganglion, as you saw in a very nice video previously, into the pterygomaxillary space medially, and of course it sends out fibers into the nose. There are procedures for vasomotor rhinitis where you can cut this endoscopically, or do a more partial neurectomy where we lift the mucosa off the palatine bone and just cut the partial Vidian neurectomy. Only the fibers are entering the nose, so as not to cause dryness of the eye. So there's some research looking at those procedures for some limited patients. This is just a sagittal view, again, looking at pterygomaxillary. These small arrows point to the back wall of the maxillary, and you can see where the foramen rotundum is. It's at the base of the pterygoid plate, up high laterally, whereas the Vidian is low. It's down at the floor of the sphenoid laterally. And as you saw, it leads to the carotid. I won't go into that, but generally this space becomes more narrow as you go inferiorly and wider as you go superiorly. And of course, laterally it communicates with the infratemporal fossa, as you've seen before. If you run into problems with bleeding, certainly in the clinic or the OR, this is an anterior artery that's we're just cauterizing with monopolar. Here's the frontal up in front, the supraorbital extension of a suprabular cell. If it's the Sphenopalatine, same thing. These things stop with simple suction cautery. The internal maxillary is the same way if you're working into the back wall of the maxillary. As far as going deeper in this area, certainly you've seen the osteology of the sphenoid bone. I think the area that we're most concerned about, and if you do fellowships and you do advanced fellowships for skull-based surgery, one of the things you have to have is a lab with cadavers, and have, just like you have temporal bone labs, you have sphenoid bone labs, okay? And the sphenoid bone is what we drill. That's what the fellows practice drilling, because that's where all the important things are. It's easier to do an anterior skull base. There's nothing much there. But when you come to drilling around the carotid artery and see all the anatomy that you saw previously, it's important to understand the relationship of the clivus and all the different foramina of the sphenoid bone. This is just a posterior view looking at the foramen rotundum, and of course the foramen spinosum and the foramen ovale over here. And what we want to do is be able to drill this area and become familiar with the osteology and the vessels that come from that area. This is a front view, which is the more likely view we're going to see is endoscopically, where you're going to reach the foramen rotundum at the base of the pterygoid. You've got the Vidian canal, and of course the palato-vaginal with the rest of the pterygoid. And of course the lesser and greater ring of the sphenoid that determine where the superior and inferior orbital fissure are. And of course there are things that we do in that area as well. And of course, the osteology from below, they all run in a line. So if you start with the foramen rotundum and base of up here at the base of the pterygoid plate, if you go back posteriorly from that level and slightly lateral, you will run into the foramen ovale. The front wall of the foramen ovale is the base of the pterygoid plate. So if you take the pterygoid plate up to dura and go to the back wall where it ends, you reach the foramen ovale, as you saw again in the nice video that was shown. If you go into the if you take the pterygoid plate down, again you saw the foramen rotundum here. Sometimes you'll see in meningoceles of the lateral sphenoid, you have to drill this base of the pterygoid plate right here to be able to see laterally into the lateral recess, but you have to be careful you don't hit the nerve. And of course the arteries can be sacrificed, but you try not to hit the nerve at the foramen. Sometimes you can take this down completely and go trans-pterygoid back to see the foramen ovale and the foramen spinosum posteriorly. This is just an infratemporal fossa view. You can do a direct view by just removing where the asterisk is, which is the pterygoid plate. And this is what you get if you do that. You go into Meckel's cave, which Meckel's cave is where the trigeminal ganglion sits, and you see the second, the first, second, and third division of the nerve. It is an arachnoid area, so there's a CSF leak if you reach that area. The front wall of this this bone that you see between V2 and V3, this is all the base of the pterygoid plate. So when you're coming from below and you remove the pterygoid plate, you will be seeing these structures. And this is just a nice view of that area, looking at the various nerves. You go V3, V2, and so forth, where the base of the pterygoid plate has been removed, and you see the entire extent of the different portions of the carotid artery. The chordomas and all that, it's important clinically to understand this, because that's where you might find small structures like this. This is a chondroma in the pterygomaxillary temporal fossa, easy to take care of, transeminent maxillary. But then you get into other situations where it's more typical of an angiofibroma like this, where of course with embolization you can confirm, and then you go ahead and resect these type of tumors, and you have to be very cognizant of the anatomy of this area.
2 minutes.
Yeah, I got it. 2 minutes actually, I have here. And so there are other lesions back in that area, including lesions of V3 here, where you go trans-pterygoid to approach that area. And biopsy in this case ended up being a small schwannoma. And again, you can get cancers in that area. You want to take it back to the foramen ovale. You have to be very cognizant of where it lies. Navigation is extremely important here. And then finally, there's the posterior aspects of the carotid artery. You've already seen a lot of that. This area we'll cover later when we talk about the clival, paraclival area. But you have to understand the different portions of the carotid. In the case of the clivus, we're talking about the paraclival area, which are these two columns that we see on each side of the sella. It's in that area where we might see petrous apex cholesterol granulomas and certain chordomas and so forth. And when we take that bone off, certainly this is something you can do in the lab as well. You drill that bone off, you show the cavernous with the sixth nerve, which is you saw previously was the first one. And again, this is a nice exercise to do if you have a little time in the lab. And then of course, this is just the same thing. So with that said, don't forget that there's also a venous anatomy around this area. And there is, and it's from here where you're more likely to get bleeding. This is all the venous plexus, the paracavernous, cavernous plexus. Actually, that's the easy thing to take care of. A different topic for discussion on how we do it, but it's certainly something to be aware of. And then later on, we'll talk about the paraclival area with the basilar artery and everything that's behind if you want to take the clivus down, you'll see that. If there's anywhere where navigation is extremely important is when you work around the carotid. So if you're anything I've talked about now, from the posterior and middle cranial fossa, we don't use navigators that much for the anterior skull base. We don't use it that much for chronic inflammatory disease of the sinuses. Not even Lothrop's we use it, but we do use it back here. And we use fusion. And we want to know where the carotid is. We'll even use Dopplers because we are drilling around the carotid artery. Thank you.
Thank you, Jason. I think we're moving out to